Good afternoon, everyone. Thank you all so much for joining today's panel event on jail and prison reentry programs. My name is Allison Gilbert, and I'm an associate professor in psychiatry and behavioral sciences here at Duke University, and a faculty member of the Behavioral Health Corps in the Wilson Center for Science and Justice at Duke Law. As a member of the Behavioral Health Corps, our group's work focuses on the intersection of behavioral health disorders and criminal justice involvement. We study various programs, policies, and services that aim to divert people with mental health and substance use problems away from the criminal justice system and instead connect them to care. The Transitions Clinic Network, which was co-created in California and Connecticut, is a national network of medical homes for individuals with chronic health conditions recently released from incarceration. Founded on the idea that the people closest to the problem are closest to the solution, each clinic that adopts the TCN program employs a community health worker with a history of incarceration as part of the clinical team. Current estimates indicate that approximately 20% of people returning from incarceration have a serious mental illness. And in a self-report survey in North Carolina prisons, there was a reported 70% prevalence of substance use disorder. It may be even higher in local jail populations. Today, we will hear from 4 reentry program experts: Shira Shavit, Executive Director of the Transitions Clinic Network in San Francisco; Joe Calderon, Senior Community Health Worker with TCN; Evan Ashkin, Director of the North Carolina formerly Incarcerated Transition Program, or FIT program; and Tommy Green, North Carolina FIT program Lead Community Health Worker and the Orange County Community Health Worker. Our expert panelists have direct involvement with development and practice in frontline programming, both nationally and in North Carolina. Today's panel will focus on how their programs meet the behavioral health needs of their program's clients, addressing mental health and/or substance use disorders via peer support and connection to services. To get this outstanding panel started, I would like to first thank all 4 of you for sharing your time with us today. I'd like to also thank the audience for joining the session and for your interest and commitment to this issue. Next, I'd like to ask each of you to introduce yourselves, your role in TCN and FIT, and how you became interested in helping people coming back to the community from incarceration who have behavioral health disorders. Shira, would you like to start?
Sure, I'd be happy to. Thank you so much. I just want to say thank you to Allison and all your colleagues for having us here today. It's really exciting to get to share some of our work with you all. I'm Shira Shavit. I'm a family physician and also faculty at the University of California in San Francisco, and I am the executive director of the Transitions Clinic Network. And I got interested in this work actually as a resident, taking care of women who were pregnant, who were incarcerated in our federal prison and were able to come out to a halfway house in San Francisco for the end of their prenatal care. And just hearing stories about how people were treated inside the prison system led me to want to learn more about that system, do some healthcare reform in the prison system, and then ultimately following my patients back out into the community and trying to learn how to better improve systems to support people who are impacted by mass incarceration.
Excellent. Thank you. Joe, would you like to follow?
I'm a returning community member who spent, at the time, close to half my life in prison, close to 20 years. I wanted to get involved with TCN because of how I was treated and the things that I seen while I was incarcerated, including 2 of my friends dying of treatable diseases. One, almost obvious to anyone on the yard, even though it was outside our scope of practice, had pneumonia, and allowed him to drown in his cell on his own fluids as he complained for weeks on weeks till he was too weak to come out of his cell. The other died of hepatitis C. Why do I love this work? Because this is community-based work. Our model is based and comes from the community voice. And I really think anything moving forward should only work correctly if you bring those to the table who the policy is going to affect, so that the community has voice, and not only the solution, but defining the problem. So I love our model. We're TCN family. We're changing systems, and I look forward to answering the rest of your questions today. But thank you for having us. Thank you for having us today.
Thank you so much. Evan, would you like to introduce yourself?
Yeah, great. Thanks, Allison, so much. It's really great to have an opportunity to talk to you all, share about the work we're doing. So I'm a family physician as well at UNC Chapel Hill, though my main clinical work has been with Piedmont Health Services, which runs a number of federally qualified health centers in the area. And working in one of those rural sites is how I started to finally, it took way too long, pay attention to the collateral consequences of incarceration, and finally put it together the incredible gaps that my patients were suffering who had those histories, and began to understand the multitude of reasons why they weren't engaged in care. I was naive enough to think that if you had chronic medical conditions, severe mental illness, of course, you'd be connected to care upon release from incarceration, because it would make no sense to do anything but that. But of course, because of all our systemic racism and other problems in our system, that is not what happened. So I decided, since we were doing nothing, we could probably do better than that. And then I learned about that Transitions Clinic Network, and I am a devotee, drank the Kool-Aid.
That's great. Thank you. And Tommy, last but not least.
Yeah, good afternoon, everyone. My name is Tommy Green. I'm the lead community health worker for the NC FIT program, and I'm the primary community health worker for the Orange County FIT program, one of our 5 sites down here in North Carolina. And why I got into this work, well, like Joe, I'm also a returning citizen. I actually did almost 12 years. And on the yard, I had made up my mind. I was never going back to prison. I knew I made a huge mistake and even getting caught up in the justice system, so on and so forth. So I always said to myself, and I said to other guys on the yard, if I ever came back to prison, it would be to help you guys. And so fast forward, long story short, I saw the ad for this position with FIT, and just reading the description, it was like it was talking to me. You know, I feel like this is my life's work. So that's one of the reasons that I do this, because I'm like totally vested in helping people that's just like me and Joe.
Wonderful. Thank you. Well, we've got a lot that we'd like to cover today, so we'll jump right into that, and hope to have about 15 minutes or so at the end for a Q&A session. Audience members can send in their questions for our panelists, and we will do our best to get to those. In other events, we've had really fantastic questions from many people who are working in the same fields or related fields as you all. So I'll do my best to get to those. We'll first talk, I guess, about the TCN model. Shira, the TCN program model aims to connect people returning to the community from incarceration to a range of healthcare and other support services, with peer support as a central feature. Can you describe this program model and how it's been successfully implemented, and with a focus on how you all meet your clients' behavioral health needs?
Sure, I'd be happy to. Thanks, Allison. Yeah, I mean, the Transitions Clinic model actually was developed in San Francisco in 2006. And I think just to take a quick step back before I describe the model, it's important to understand the process in describing the model, which was very much a community-led process. Here in San Francisco is a collaboration between providers and our local county health system, along with community advocacy organizations, legal services for prisoners with children, and City College of San Francisco, really with an eye to thinking about how can we transform our health systems to better meet the needs of people coming home, with a real understanding, kind of as Evan alluded to, that our healthcare systems really are not meeting those needs. And so, you know, through a series of focus groups and working with the community, we developed the Transitions Clinic model of care. And the Transitions Clinic model of care is really aimed at transforming primary care systems. So taking existing health systems and layering on this additional program, changing what the clinic does to meet the needs. The kind of number one key feature is embedding community health workers with lived experience of incarceration into primary care teams, so that these individuals who have the experience and knowledge of the impact of the systems on people are able to be part of the team and contribute their experience, and also act as cultural interpreters on the healthcare team to really support the patients. The community health workers support patients in both health system navigation, navigating the social determinants of health, as well as providing emotional support, mentorship, advocacy to address policies that may continue to punish people once they've come out of incarceration, along with building relationships with key partners like the criminal justice system and other reentry organizations. Some of the really kind of key features of the program is really that all of these programs enlist people with histories of incarceration as part of the teams, both to design the program, implement the program, and evaluate the program, and really transform what we do in health systems to put the community at the center. And, I think many of us know that, oftentimes healthcare can be a sort of more kind of top down, less inclusive of communities. And so we're really hoping to, transform that with this model. Some of the other key features that we ensure are embedded in all of our programs are things like ensuring that people are integrated into community health systems when they come home. We don't, what we heard from the community is we don't want separate systems for people who are impacted by incarceration. We want to be integrated into clinics where our families and our other community members are being seen. We also heard from our community that people wanted all of their health needs addressed together, and that they wanted the health systems to take a broad perspective on health and well-being, not just focusing on their physical health or on their mental health or substance use issues, but seeing them as a whole person and all of their medical needs, as well as their social determinants of health. So the program is really geared at looking at people kind of from a broad perspective. Some of the other key features of the program include that what we heard from our community is they wanted to know that we were not replicating the criminal justice system, that these programs were, by them, for them, and that they knew that when they were seen in these programs that what was shared with the providers, with the team, would remain confidential and not shared with, if they were on community supervision, like their parole or probation officers. So those are some of kind of the really key features of the programs that we have that are embedded within our primary care systems.
Excellent, thank you. And Evan, you developed and piloted the NC FIT program in Durham County in 2017, if I'm correct, with funding from the North Carolina Department of Public Health. And it's since expanded to other counties around the state of North Carolina. As I noted at the start, you'd shared that current estimates indicate that it's about 20% of people returning from incarceration with a serious mental illness, and as much as 70% with substance use disorders. Can you describe why implementing this program in North Carolina was important, what your program looks like today to address behavioral health needs as people return to the community from jail and prison?
So in North Carolina, which sadly is true really across the country, a lot of reentry programs, reentry services have not included healthcare. I mean, it's actually this pretty stark absence of healthcare providers. And it was the same in Durham, this quite progressive community with lots of resources, Duke University, plenty of wealth, and a very strong actually reentry council, but still no connection to primary care services at all, and pretty limited connections to behavioral health and substance use treatment. So, there was, even though all that existed, there was really a need for something like FIT, which was, it's completely based on the TCN model, to have an opportunity to make these linkages. And I will say, we also, to this point of linking people with behavioral health, we saw that as a very significant issue. And in North Carolina, we did not expand Medicaid in North Carolina. So we have, many people who, if you don't have disability from your severe mental illness, you are uninsured. So people, who don't have like psychotic disorders have incredible difficult time accessing any type of behavioral health services. So we actually were working, and this is, we're looking at this model with a clinic in Raleigh that's now a FIT clinic, where they focus on doing primary healthcare for people with severe mental illness, and really using the FIT model there as well to try and see if we can have the same results for people with significant mental illness that TCN has shown sort of more broadly.
That's great. And I would think another challenge too is fighting against misconceptions that somebody that's been incarcerated for potentially many years, who had and has substance use disorder, is not at risk for returning to use because they had maybe not been using for a number of years while in prison.
Yeah, and we even, as you know, cursory look at the data, we know that that's not true. And
Yeah.
just, you know, in North Carolina, the overdose death rates for people post-release from the prison system in the first 2 weeks are 74 times that of the general population for death from heroin overdose and 40 times that for any opioid overdose. So clearly, as far as substance use disorder, that's a fallacy, and it certainly is for mental illness as well.
Great. So we'd like to hear next from both Joe and Tommy about your work as community health workers with these programs. And if you could tell us about your role in TCN and in the FIT programs, and how and why your work is critical to the success of the model and the programs themselves. Joe, would you like to go first?
Sure, that was a long question. But if I heard it correctly, we're asking about the success of the program, and I'm going to go straight to the secret sauce. You know, Dr. Shavit often refers to us as the secret sauce. I didn't want to say that earlier in case she was going to do it in her presentation. I probably just messed it up. Sorry, Dr. Shavit. But, you know, I really think I go back to what I said earlier when I spoke about community. And I think our success has really been that, listening to the community, letting them identify the problem, let them come up with the solution. And then we came out with this model. It's you know, it's from the community. That's why it works. And why else does it work? Because the community health workers come from the community they serve. Now, if, you know, sense was common, I could argue with you all day, but common sense would tell you that community health workers should probably come from the community they serve so they can build relationships that keep people in continuity of care. You know, our success is based on really listening to the people and giving the people what they wanted. That was something that would be empowering to the community and system changing at the same time, bringing men and women with histories of incarceration into clinics, and not just, you know, answering phones. No, we're part of the medical team in this model. You know, our experience is respected, just like, you know, anybody else's letters that had to spend quite a few years to get them. Just like I had to spend that 20 years in prison and whatever else years on the streets to get the experience and the skill set that I have that I utilize today to keep people in care. I don't want to take too much time. I hope I answered your question, but let me leave some time for Tommy and then I can come back to that if there's any other questions. Come on, Tommy.
Sure. Yeah, that sounds great. Tommy?
Yeah, thank you, Joe. And to echo what he said, I mean, you answered it perfectly. As Shira says, I'm sorry, I always mess up your name, Shira, sorry. But anyway, so like he was saying, the secret sauce is us, and I'm not just saying that because I'm one of the us that I'm speaking of, but it's just like the commonality that the power of the commonality we have with our clients is almost undescribable. Me, I've kind of like developed the habit of like talking to people, meeting people, letting them get to know me before I reveal that I'm justice involved. And so I carried that habit onto my clients. You know, I would talk to them about the FIT program, the ins and outs, the importance of healthcare, so on and so forth. And then I'll tell them, hey, I'm also justice involved. I did this amount of time. And it's like the response is like day and night. In the beginning, yeah, they're kind of getting it. They're kind of hearing where I'm coming from. But when they find out that I was in prison just like they was too, and I had to navigate these same systems that I'm trying to show them how to navigate, it's like, wow, now they're open to it. Now they get it. Now they understand it. Now they trust these things that I'm saying. And with that trust comes trust that I can pass on to Dr. Ashkin so he can so he can do his job. I'm put it like that, leave that word out. But so anyways, again, so just to be able to have that commonality with our clients has been super beneficial. And again, being able to vouch for the actual healthcare they get, because again, with this population of people, they have been so penalized and so stigmatized when it comes to anybody in any type of authority, whether it's in a job setting, in healthcare setting, so on and so forth. But another thing that we have to realize in dealing with this population of people, that when it comes to the things that they're facing, the barriers they have to face, healthcare is at the bottom of the list. Everybody wants to find housing first. Everybody wants to secure transportation first. Everybody wants to secure employment first. But then everyone has to come to the realization that your healthcare trumps all of those. You can't be official in none of those other aspects of your life until you get your healthcare on track. So once we instill the importance of that into our clients, the relationship is awesome. The results are awesome. We see life-changing things happening in these people's lives, and it's just beautiful.
Thank you.
Can I jump in here real quick?
Absolutely.
I just want to underscore what these, two gentlemen are saying. And I think it's really important to understand kind of one of the key pieces here that Tommy touched on, which are kind of all the barriers that people face when they're coming home from incarceration. And we actually have a term for that, which I'm sure many people on the call are familiar with, which are the collateral consequences of incarceration, which are laws and policies that continue to punish people even after they've done their time in the criminal justice system. And we know that there's documented over 40,000 nationally, and the large majority of them are impacting employment. And when you start really breaking that down, a lot of them are related to occupational licensing, jobs in actually one of the #1 spaces where people with felony convictions have trouble getting employment is healthcare. And I want to make sure we just kind of touch on this because we're going to be talking a lot about this community health worker role, but I think it's really important to understand how profound it is to hire people with lived experience or criminal records into the healthcare space. And so, I didn't mention earlier, we started the program in San Francisco. We've expanded it to 48 different health systems in 14 states and Puerto Rico. And kind of really at the foundation of that work is that when we say system transformation and hiring the community health worker, it's really pushing back against those collateral consequences of incarceration that has excluded people with lived experience from working in the healthcare sector. And so I just want to kind of put that in people's minds, and you're thinking about this work and thinking about that transformation. And a lot of our work at TCN is supporting health systems in doing that. But that is really, why the voice has been excluded so much in the healthcare system and what has really kind of perpetuated a lot of that mistrust because it has been the systematic discrimination from employment within that system. So just wanted to kind of raise that issue as we kind of start talking more about the programs and working with the clients.
Absolutely, thank you. And you mentioned, Shira, about the diffusion of the program and it's being implemented around the country, which is very exciting. I think in thinking about program models and then the implementation of a model in different settings, inevitably there will be need for some adaptations to the model. But then you also think about there might be fundamental aspects of the model, say the inclusion of community health workers as a good example of that, that really must be implemented consistently for a program to achieve success and be what it wants to be. And Evan, I'll ask you about this next, but thinking about you're having implemented the model in North Carolina, which is very different from my home state of California in many ways, in terms of politics, policies, resources. Shira, I wanted to ask you if what this has looked like as the model's been implemented across the country, and what you can say about adaptations that are needed, but also some features of the model that really must be in place.
Yeah, absolutely. Yeah, I mean, I think some of the really core features, as I mentioned, are community health workers with lived experience, working in healthcare teams, transformation of the health systems to meet the needs of individuals, building bridges with the criminal justice system, although this may look different in different communities, and then building relationships with reentry resources, are kind of the core features of the model. I mean, I think even more importantly are those core values that I talked about, including people impacted in the design, implementation, and evaluation of programs, incorporating a broad definition of health and well-being, adapting systems to be patient-centered, to meet the needs of the patients, not expecting the patients to meet, the systems, but changing systems to meet their needs, focusing on empowering patients, favoring reintegration, right? Not creating separate systems and avoiding replication of the criminal justice system. So kind of with those, key features of having the community health worker working part of the team and changing how the healthcare system interacts with the criminal justice system and community, health system and social service system is kind of the core feature of fidelity, but we see so much innovation. And that's what's been really wonderful about this work, and kind of one of my favorite parts of the work, and in particular working with our colleagues in North Carolina, because they are really innovative and they have a very different set of resources. As Evan mentioned, they have not expanded Medicaid. They face unique challenges. Just even getting medications for their patients is so challenging. And so what we see from our programs is a lot of innovation and adaptation based on the resources they have available in their community and also the needs of the community. And so because we have a network, we can share those innovations across the network and learn from each other. So, I think about, for instance, one of our programs in California in Contra Costa County, they started doing support groups in their clinic to help men and women who are returning, help with their kind of well-being and adjustment to being in the community, and then took those support groups and started doing them inside their local county jail. And so that was like a really wonderful innovation that we're all learning from. They call it Remedy, which is a way to support people kind of even beyond their medical needs and thinking more from a healing perspective. So that's one example. I think North Carolina is a great example of how, because of the high need of overdose in the community, and I don't want to steal Evan's thunder, so I won't talk too much about it, but all the amazing work that FIT is doing around FIT Connect and ensuring that people get access to the medications for opiate use disorder and other substance use treatment that they need. So a lot of it is based on the necessity, the resources available. And what we also do as a network is not just innovate, but we also are trying to understand the impact of our work on communities. So we also do a lot of research and evaluation and work to move the science forward to better understand the needs of this population. So suffice it to say, there's a lot of room for flexibility and creativity amongst the programs that we ultimately share with each other, and it moves the work forward nationally together.
Great, thank you. Evan, can you please tell us how your programs have been designed based on the TCN model and ways in which they've needed to be adapted to fit the North Carolina community context in which FIT programs have been implemented? And also I'm thinking about, challenges of rural settings, and also, of course, our state not having expanded Medicaid. So as you've said, the vast majority of people returning home to the community from incarceration being uninsured.
Yeah, I mean, we obviously, our political landscape is different. Our resources are different. I would say, Shira and Anna Steiner, the program manager, were very clear day one about these essential parts of fidelity, and it is just proven over and over again. So I can tell you the challenges that we ran into, obviously, were one, our federally qualified health centers are barely keeping the lights on because we didn't expand Medicaid. So they didn't have the resources to hire community health workers. So we had to do something quite different than TCN normally does, is look for other community partners that could, in a sustainable way, so we weren't writing grants 24/7, employ the community health workers. And actually it worked out very well in like Durham and Orange County, which are very progressive, where the health departments were willing to take on hiring those folks. But then you have this challenge of embedding people into the FQHC effectively. So that has been a different lift for us. And it is definitely doable, but it takes another level of engagement with the FQHC since they're not employed. And then say the other thing which Shira has talked about and Joe and Tommy reflected on is this barrier to hiring someone with a criminal record. And again, in a state like North Carolina, I don't know California, but there are many barriers, and you have to push back a lot. When people say, "Oh, well, you can't hire," this global statement, someone with felony conviction, and the answer is you absolutely can hire someone with a felony conviction. Like, where does it say you can't? What are your barriers? What's your policy? Who said you can't? And it's almost like that excuse if you're in healthcare with JCO, right? Oh, we can't do that because JCO says you can't, right? So people say you can't. So that was a big thing we had to do, was push back against that so we could have this essential fidelity of our community health workers having lived experience. And then I just want to also state that putting the community health workers' voice first it is again something that I don't think we can stress enough. So all of our work we do behind the scenes also has our community health workers part of those, every one of those conversations, our research team, our implementation team, everything we do has the voice of our community health workers there helping to lead the discussion. So, and I think the other thing that really, really helps is there are many people in your communities, if you're thinking of doing this, who are very invested in reentry already. They know there's this incredible lack of connecting people to healthcare. So if you can find those folks that are doing reentry work, and then you will get tremendous support in adding something like a TCN model clinic.
Thank you. And with our, thinking about the two different contexts of North Carolina and California, in California with Medicaid expansion, Shira, would it be correct to say that the large majority of people returning from incarceration to the community are eligible for Medicaid with expansion, even upwards of say like 95%?
Yeah. So, I mean, I think nationally, there's been Medicaid expansion. The ACA has been a policy that has really driven the work forward tremendously, giving people better access to coverage. What's interesting, though, is that there are two studies that have shown that even in spite of that increased access to coverage, it doesn't always translate to increased engagement in services, in particular in mental health and substance use treatment. And so I think this is where our model really comes in, is this engagement piece of how do we, as the community said, adapt systems to be patient-centered. How can we change what we do to get people in the door? How can we support people kind of with all of their needs, their competing priorities? And so I think, while unfortunately not all states have yet expanded, and that's a tremendous barrier, even in states that have, when people have coverage, that doesn't always translate to improved treatment or use of services.
Yeah, we've had to raise money to cover the copays at the FQHCs and for the meds. And that has been an incredible barrier, probably non-sustainable, but it's incredibly frustrating that we are spending so much time trying to cover that $25 copay and the $4 per med a month. It's pretty ridiculous.
Yeah, absolutely. And it's interesting, Shira, I remember from our conversation back a few years ago, you're having said just what you did now again, and I was going to ask about that, but that, having expanded Medicaid is critically important, but it's also not the magic bullet that solves all the problems. So thank you for reflecting on that as well. Next, ultimately important topic. There's been increasing and really much needed focus on identifying and addressing racial inequities in our communities, including in our public systems and institutions. And it'd be great to hear from all the panelists. Can you talk about how TCN and FIT are addressing racial inequities, and especially how they affect your clients with behavioral health needs?
Let me just jump in. I mean, in North Carolina, our state's at 22% Black, and our prison system is 51% Black. I think as Joe mentioned early on, this is the final common pathway of a lot of systemic racism is incarceration. And so almost by doing this work, it is so equity focused, and clearly I think you will find, if you're working with many community partners who are trying to, who have direct experience, people coming out of incarceration, there's an advocacy bent toward almost everybody. So I would say part of the thing, and Shira mentioned this, is there's a lot of room for advocacy, both locally and in your state, to really try to address the drivers of incarceration. So I think that's another way that this work really is directly impacts these disparities.
Joe, would you like to reiterate? Sorry, excuse me. When the panelists and I were signing on, we were having a little early conversation. Joe, would you like to reiterate some of what you were saying in that regard?
I'm a one-shot Erskine, you know. I might not remember exactly what I said, but, you know, on this note, you know, when we think about inequity, who are we serving? When we think about mass incarceration, who did it affect? You know, so, you know, let's be honest, you know, knowingly or unknowingly, these were wars on communities that were Black and brown. You know, a majority of our clients then are who? Those who are up against racial inequities, stigmas, and awful racist policies. So when I think about what TCN does is, you know, there's no easy fix, but we're a part of that fix. Because, you know, if I, you know, when I was a CHW in San Francisco, you know, my elevator pitch would be telling you that we work with men and women coming home, teaching them to navigate the medical field and looking at the social determinants, public health 101, where we're not just a clinic where you're going to come and get a shot and we'll see you later. Go deal with your life now. No, we look at the social determinants and have an understanding that this population historically has just been up against it. And so, you know, how do we address that? By empowering our community, by hearing their voice when we create the program, by making sure that they define the problem. Our CAB today is active, and all of our CAB is previously incarcerated and our patients, you know, and they come and they give us stone cold feedback, and we act on it when it's appropriate. I don't know if I could say anything else, but, you know, when we think about what we do is system change is necessary if we're going to look for health equity. I would like to say equity, but we got to get health equity before we can get equity. I think that's our best bet. And I'm going to leave the floor for somebody else now.
I just want to say everything that both of them just said, and I think also big part of what we do addressing racial equity is like events and things like this. You know, the advocacy portion of our programs is the most important. Prime example, I'm like the worst. I have the worst stage fright in the world. I am terrible about speaking in front of people, but you know what? I'll hit the stage every day if I can, just to be that voice for the people that don't have a voice right now. So I think, you know, again, advocacy is our like biggest weapon in our artillery right now.
And I'll just, you know, add one other kind of additional perspective. You know, I think kind of as Evan talked about, mass incarceration is systemic racism. And then we know that people of color face systemic racism in our health systems. But when you're talking about people who are coming out of the criminal justice system, there's a whole nother layer of discrimination and stigma that people face because of their criminal record. And there was a study done by our colleagues in Canada where they, not we, I'm not Canadian, although sometimes I wish, where they have, you know, universal coverage. And this study actually looked at when people called primary care clinics looking for appointments, if they identified that they were recently released from incarceration, they were significantly less likely to get an appointment in that health system. And so there's this other additional layer of discrimination and stigma people face in trying to get healthcare, and that impacts their health equity as well. So I just wanted to kind of add that in addition to the racial inequities that our patients face.
If I may briefly, Tommy touched on it earlier, right? There's nobody walking around on those yards thinking about healthcare as part of reentry. So one of our struggles when we think about, you know, funding and politics is, guess what? Healthcare is reentry. Men and women coming home with chronic conditions need services, or they're going to abuse the ER, or even worse, just die, right? That story out of Washington said, you know, within the first 2 weeks, we're 12 times more likely to die than the average person. Within the first 2 weeks. Those are numbers that should not be numbers in the United States of America, let alone anywhere else in the world, you know, with the resources we have. But I just, thank you.
Thanks to all of you for sharing your perspectives. Let's see. I'd like to talk now a little bit about qualifications, experience, training for community health workers that are such an important part of the program. Shira, maybe you can start. Can you tell us about what qualifications and necessary experience you established for TCN community health workers, and what kind of training or continuing education is available to them? it sounds like, from what we've heard today, that their own lived experience and commonalities with the people that you're providing care and services to is number one. Can you tell us some more about that?
Absolutely. So again, community health workers with lived experience of incarceration. So we're looking for people whose lives have been impacted by the criminal justice system. On occasion we'll have programs like, oh, this person was in jail for 1 night or 2 nights. And, we're really looking for people who kind of understand that deep experience, what it feels like to be, apart from your family, to lose your autonomy, to have no confidentiality, to live in this system, to be dehumanized in this way, and then return back to the community and try to reintegrate. And so someone who can kind of understand the breadth of that experience, someone who has successfully returned to the community. I think oftentimes it's sort of tempting to create these jobs and think, oh, we'll give them to people right when they come home, because that's when people often need work. But reentry is a process and it takes time. And so we're really looking for people who have completed kind of that whole process of reentry successfully and understand sort of those components. And I'm sure Joe and Tommy can speak much more to this. We're also looking for people, these are individuals working in the healthcare system. So this is, they're working with complex patients with complex needs. They often have to work utilizing the electronic health record. So we're looking for people who also have some experience working as case managers, as community health workers, peer support specialists, who have those core competencies or bring a majority of those core competencies to the table. And we have ways of assessing people's core competencies and where they may have some training gaps, but really looking for people who have those experiences. And they don't have to have that formal kind of certification. We really value the work as a community health worker within a prison or jail setting. And we know oftentimes people are working in those roles, not even in the community. And so we value that as well. But so we're sort of assessing people kind of along those lines. As far as just thinking about the qualifications, we also, our organization does provide training for community health workers to help them leverage their own experience to better help others who are coming home from incarceration. And Joe, who is our lead community health worker for Transitions Clinic Network, trains and teaches all our new community health workers in a 12-week online training how to best support people with chronic conditions returning from incarceration.
Evan, do the FIT programs look similar or different to that? Can you talk about training and experience for community health workers?
It's the same, and our folks participate in this program, same qualifications. We have to teach them more about medical insurance, sadly, so they can be effective. But otherwise, no, I don't have anything else to add.
Okay, great. And
if
Joe,
I may,
oh, sorry. Yes.
if I may, when we think about hiring CHWs, it's a really, really important topic. I really believe that, the success or failure of a clinic will be on who you hire as a community health worker. Does this individual really have linkages to the community? Where are their roots? What have they been up to? Shira and I kind of have a little, rules are meant to be broken, but we have a little rule that we believe 2 and 2 works. Somebody that's done at least 2 years, someone that's been home at least 2 years. It shows a track record. Passion of service or healing is not something that just appears usually out of anywhere, right? So, like when I came home, I wanted to be a part of the solution. I mean, I had my feet moving, and I still do. And I just think that Transitions provides us the opportunity as being returning community members to come back and empower our community. It's just really, really, I'm going to use a 90s term, quote unquote, off the hook. It's great that the community's voice is being heard. You like that, huh, Tommy? And respected. But, if we don't reach back into the community to get the answers and we continue to dictate the solutions, not much will change. This is change. And I would say get on board. If it's not us, who? And if not, now when? Let's do this, guys. I know North Carolina's on fire, so is California. Let's go. Let's go.
Also, I want to add, Joe, you said the magic word too. It's the passion. That's why I like dealing with Joe. I like working with Joe. I like hearing Joe talk because you can hear it in his voice. He's really passionate about what he does. And that, to me, has got to be a key ingredient in any good community health worker. You got to want to be that piece, that missing piece that these clients are looking for, that these clients need. You got to be able to relate. You got to have that empathy, all of the above to make a good community health worker. On top of all the extra training, of course. Because like me, I was green when I came into this profession. I had zero knowledge of anything dealing with healthcare. God blessed me to come home in totally perfect health. The mental health, I don't know, my wife might not agree with that or whatever, but anyways, I didn't have no underlying issues. So I couldn't really relate to that per se, but again, I could relate to all the plights of anybody returning to the community. And I was dealing with a sick father at the time. He had a chronic condition. So I had a little bit of experience with helping someone manage a chronic condition. But as far as really knowing the ins and outs of it, I was green. But I think, during my interview, they could sense my passion for the work. And they knew that, this guy's really going to do everything he can for his clients and to learn, about chronic conditions and how to treat and deal with this population of people. So I think, again, in my situation, my passion overrode all. And I think that, again, that's a very intricate piece to have in a community health worker working with this population of people.
Thank you, Tommy. I just want to make a quick announcement. If this would be the time, if folks in the audience have questions for our panelists, please go ahead and put those in the chat, and we will get to those. We do have, let's see, we have one here. Can anyone identify any role for a parole or probation officer or service that is not a program like FIT or TCN? Would funds now used for justice system, parole, or probation follow-up be better used in public health budgets to expand the programs and mandate, quote unquote, healthcare and behavioral health services that are separate from jails, prisons, courts, especially as probation and parole appear to be instrumental in return to jails?
The culture of parole and probation has to change. Parole and probation are bridges to society. When I did 20 years in prison, so when I was in prison, I constantly seen this cycle of men and women, men coming home and back to prison and telling me about what was going on there. It was always dark. Now, some of them might not have been, following all the rules, but what I found out when I came home is parole and probation can really dictate the success or failure of an individual. And I think the culture of parole and probation, like the healthcare system, it needs some changes. And thinking about how we're serving our community and, quote unquote, are we keeping our community safe with the policies that we're using? And I'd say no. I think we got another question about COVID, but I had a success that I wanted to share too, but I'll wait for that question. Sorry.
Yeah, any other questions that are coming in, Melissa, if you text those to me, we'll get to those too. I think I did see a question that asking if programs like TCN and FIT work with juvenile populations.
I can answer that. The model was created to support adults and in the primary care setting. So many of our sites will work with the adult person coming home from incarceration and all their family members. So that would include their children. But as far as adapting the model to specifically do linkages to the juvenile justice system, we haven't done that yet, which I think could be done. I mean, I think some of our programs are working kind of with the transitional age youth, kind of younger, early, late teens, early 20s. But as far as kind of like specifically juveniles, that is not something that we have really delved into, but I think would be really excited to think about how we might adapt this work for that population.
We had a preliminary conversation with hematology group caring for younger people with sickle cell incarceration and talking about doing for that small group, but trying to help facilitate transitions back to healthcare. It hasn't started yet, but I'm hopeful.
Thank you. Here's another question. Is Is the 12-week training for community health workers available for people outside the network?
Feel free to write us offline. We can have that conversation. We have trained other community health workers with lived experience that are working in partnership with our TCN site. So in Los Angeles, for instance, the county has supported TCN programs and community health workers with lived experience in community-based organizations. So we have done some of those trainings with those community health workers. For now, though, our trainings are limited to community health workers or peer support specialists with lived experience. So if that's the situation, I'd be happy to have a further conversation.
Thank you. Here's another question that, sorry, go ahead.
Well, I did see a question earlier about like specifics. I just want to be clear, like Joe and Tommy are not sitting around like making referrals. This is very hands-on works. Like, you know, Tommy is coming to clinic. He is working with clients. He is getting them their meds. He is bringing them their meds. He's taking them to the food bank. He's going down to the court and talking to the judge about their participation. He has supervised visitation with or custody for, so it is, when people say what it's, so it's very hands-on. It's not for the faint of heart either, because you're out there. And so I just want to make it really clear, this is not about a referral service. This is actually about direct service and really making those linkages, taking people to the shelter. So just want to sort of clarify that really important distinction, because a lot of reentry programs are about, oh, someone comes in, I'm going to refer you here, refer you there, refer you there. It is much more direct service, hands-on.
Yeah, and just to quickly add to that, you know, it's about building relationships. And I know people are interested to know about pre-release. And, you know, some of the data coming out of our network shows that building those relationships early while people are still incarcerated really improve engagement and care. So one of our programs in Santa Clara County found that when their community health workers went into the jail and met people before they were released, it improved show rates in their clinic from 33% to 70%. And North Carolina is doing incredible work where their community health workers are also meeting people pre-release. So I think it's really about that relationship building, the trust, the engagement piece. And I just wanted to throw that in there because I did see a few chats around pre-release and kind of that connection to the criminal justice system. And so point out that that is something that is being done for many of our sites across TCN as well.
Yeah, thank you for raising that. I was actually had another couple of questions that related to opportunities that your programs have for doing in-reach to prisons in anticipation of somebody returning to the community and getting engaged with them, you know, as they're coming home. Another question I'd had that I think Joe and Evan, you and Tommy helped answer was, you know, what's needed to engage people and sustain that engagement in the program. And Evan, what you described that Tommy's doing on a daily basis is really powerful and helping illustrate that. We've got, let's see.
If I may really quick, you guys, you must understand the competing reentry needs. You know, like I said earlier, ask Tommy, you know, he did 12 years. Nobody's usually in that fishbowl or in prison talking about healthcare. And so when we think about system change, one of the things we got to do in our own community is every time we're reaching back in is telling them about healthcare, because you can't get a job. You can't be habilitated. You know, you can't do all these different things if your medical's not right. You know, I often tell them, you know, people with money live longer because they have access, you know, to medical, and we don't. But with the ACA expansion, it changed the field in California. And, you know, I know FIT North Carolina, you know, old school, you know, they're hustling to make it happen, you know, because the expansion didn't happen. And that is kudos to, you know, to the work that they're doing in North Carolina. I just had to mention about those competing priorities, because if you don't have a sense of what's going on in someone's life and you're just at the clinic and you're just oh, they didn't show up. They didn't show up twice, put them on a list. You know, we're dealing with the population that's severely traumatized, and in many cases just don't know how to navigate the medical field, let alone anything else. Thank you.
Thank you, Joe. Let's see. How does TCN and FIT navigate medications for opioid use disorder and promote health generally for individuals with substance use disorders that are within the current criminal justice oversight system? And are collaborations with DOCs helpful, or do they create more harm?
Sure.
I mean, we are stepping into this arena and have learned some lessons the hard way, but I can say that there is, in North Carolina right now, there's tremendous interest in the jails and prisons in getting this going. So we have found partners. We've actually have now programs in both Orange and Durham because of our FIT programs where people can stay on MAT when they're in those jails. And actually we're just starting initiation, and the prison system, you know, we have a good track record with them. And now we're working with them to do a pilot in 3 prisons to start MOUD, and one of them is women's prison in Raleigh. So I would say that, you know, you have to go in with eyes wide open and understand, you know, there's some risks obviously about being, as Shira mentioned, being associated with departments of corrections, but there's also an incredible need. There is a moral imperative, I think, to offer this life-saving treatment, which we know 61% reduction in post-overdose deaths if you link people to, if you start them on MOUD, MAT prior to release and continue them. So I think it is a super important area to engage in. And there are many pitfalls. Talk to Shira regularly if you're gonna do this work so she can help take the blinders off so you don't make too many mistakes.
Yeah, I'll just add to that. I mean, I think this is one of our core values of not replicating the criminal justice system or sort of this punitive system. But that's a big statement. And what does that really mean in practicality? And I think that's where the community health workers come into play, where our community advisory boards come into play, where we bring these ideas, these programs to the table and we say, well, what does that mean for this community? Like, what is replicating the criminal justice system and what isn't? And working with the criminal justice system or engaging with people inside doesn't mean you're replicating that system. I think it's important that we work as partners and support people in those systems. But I think it's just really critical. We're healthcare providers. We want to build relationships. We want long-lasting relationships. We want continuity. This is about engagement and people coming back. We know when people have substance use disorders and they relapse, we may lose them for a minute, but if we have positive relationships, that they may come back to us. And so we're really in it for the long game, and we're not looking to kind of punish people or make them feel like they don't want to utilize our services. And so I think, you know, a lot of our work is sort of figuring out what does that look like and how do we support our communities and ensure that we're not inadvertently becoming the arm of that system that we're looking to change. And so again, it's often a conversation over time, and critical that the community is involved to ensure that we kind of stay the right course in that way. And I think that kind of answers the person's question earlier around kind of where funds could go, you know, to support this community, you know, in probation or parole versus the healthcare system. I think what's most important is kind of, you know, that the healthcare system is using these funds in the way that best supports kind of the health, well-being, and you know, empowerment of the communities that we serve, because that's what we are as healthcare providers. That's what we want to be doing ultimately, right?
I have a follow-up question that's also getting back to the Medicaid, expanded or not. This would apply more to the California programs and other states that have expanded Medicaid, but is part of the reentry planning for folks that you're hoping to connect with TCN once they return home to the community, is Medicaid either first-time enrollment or reinstatement something that can happen before they're released from incarceration? And that would apply here in North Carolina too, for the, you know, for the many fewer who are Medicaid eligible.
Yeah, enrollment is a critical part, you know, enrolling people while they're incarcerated, thinking about terminate, you know, suspension versus termination.
Yes.
And when people are coming out, even enrolled in Medicaid, sometimes there's a lot of administrative barriers people face when they come out, and we've faced that a lot with the pandemic, right? As people are technically enrolled, but they're not active, and they have to let the Medicaid office know that they're no longer in the system. So there's a lot of complexity in that enrollment piece, but it is a really critical component. Our programs are more about helping people navigate kind of that enrollment component at the clinic level or when they're coming out. And then we are always encouraging criminal justice systems to do work around more enrollment, statewide policies around suspension versus termination. Some of our programs do have contracts with the criminal justice system to go in and do enrollments, like in their local county jails. But that is a very important piece to this whole part of the work, but is not, squarely necessarily part of our model. It's, we're more involved probably in the navigating the enrollment piece than being a big component of it.
We're exploring a medical legal partnership with North Carolina Legal Aid for all of our clinics to help address that, Allison, so that when people are denied benefits or have other issues, that they have someone much more skilled than us to help advocate for them in that system.
Thank you. We've had a couple questions. Do TCN and FIT have partnerships or resources for older adults? For example, working with area agencies on aging to screen for services, et cetera.
We work with our whole community. So yeah, aging adults, quote unquote, I believe because of incarceration, there's organizations that count seniors starting at 50, because of the wear and tear and trauma of the incarceration and the revolving door can do in a person's life, let alone the community suffering both socially and economically. So, sorry, I got lost right there for a second. I was just thinking, when I think about our community, this is the right path to go. I know earlier someone was asking a question about similar to that, but I'm going to back up and let someone answer that question. I'm sorry, guys.
The comment I put in is it depends a lot on the FQHC that we work with and whether they have developed those relationships. Tommy, what were you going to say?
About the same as you and Joe. We work with the entire community. We have a small number of senior citizen clients or whatever. And we do make some connections for them in the community, hook them to senior services and assist them with getting their Medicaid cut back on. And just to back up to the Medicaid question, long story short, it's like rough in North Carolina to get Medicaid cut back on, so on and so forth. Me and Dr. Ashkin have this conversation all the time. It's like a person goes in, within a couple of days, it's cut off. They get out, it takes them 2 years to get it cut back on. So it's a slippery slope to navigate Medicaid in North Carolina, on top of the big slap in the face of us not being a non-expansion state.
Yeah, that's a running theme for sure. And the challenges that we face here is the lack of insurance. And we've seen that in other work we've done too, including with recovery courts in Wake County, for example. But just that within the population of people that we aim to serve, it can be as many as, upwards of 95% are uninsured and not eligible for Medicaid at this point. So hopefully that'll change. Well, let's see. So it is 1:36, and I think it's sadly, in my mind, time to wrap up. But I wanted to give the opportunity for each of you on the panel to give one last remark about your programs, what they mean to you, what you think is the center of the program, and last words you wanted to share with our audience.
If I may, during one of the questions, we definitely touched on how COVID-19 has increased, the stressors on returning community members. But I want to share a success in California, one of a kind that I know of. In California, when this happened, we came together as a team and talked about what we could do for our community. And we developed, like I said, what I believe is one of a kind hotline in California, where men and women, while incarcerated, could actually call and let somebody know where they're paroling, and they'll talk to a community health worker with a history of incarceration and building relationships even there. And then what they do is find them a health home prior to release. So that way, ideally, we would like to get everyone an appointment within the first 2 weeks, acknowledging, the study that came out of Washington, it said we're 12 times more likely to die in the first 2 weeks. Thank you.
Thanks for that, Joe.
I just want to say, again, this organization is a great organization. The model that Shira and her people's put together for us to follow is phenomenal. Again, I love to say that, this is my dream job. I'm living the dream, being able to work with this population of people. It's very rewarding, very humbling work. I've actually joked with Dr. Ashkin before, I could win the lottery tomorrow for $1 million and I'll still be the lead community health worker for the FIT program. So, and what I think is the real secret sauce again is me. No, I'm playing. But yeah, again, the relationships that we have with our clients, I think that's going to keep both of these programs around for a long time. And anybody, if I had to give any advice to anyone that's doing this type of work or that's thinking about doing this type of work, just keep in mind, again, like Joe said, getting people from the community to work with the community is going to always be the most beneficial piece to working with this population of people. Also, thank you for having us on too. Really appreciate the opportunity to share our work and our thoughts about our work with the world.
Absolutely. You're welcome. And thank you. Evan?
Just the final word is that this is, in medicine, I just feel like we have failed just profoundly to address this work with this population. I mean, I've been in progressive causes my entire career and it basically never came up. Not talked about in med school, residency, the opportunity to help to push against this dehumanizing system is remarkable. It is by far the most gratifying work I've done. I am so grateful to be doing this. It is embarrassing caring for folks coming out of the system because the care has been so subhuman that people, it's just embarrassing, honestly. So I'm so grateful, and I really would encourage everyone to learn as much as they can about this work and lift the conversation. And what Shira and her colleagues have done in lifting the voices of people impacted as to become more visible is truly inspirational.
Thanks so much, Evan. Shira, would you like to make a last remark?
Thanks. I just want to thank you, Allison, and your colleagues, and thank the audience. You guys are incredible. I mean, the comments, the chats, the questions are so great. Clearly, you all are here because you're really dedicated to changing systems in your own community and are deeply thinking about how to best support the clients that you care for. And, I think, as mentioned, this is just a framework that brings people with lived experience to the forefront. We've created a structure and support for people who want to do this work. So I just encourage everyone to reach out, whether you're interested in caring for older people or juveniles or women who are pregnant. I think thinking about how to adapt this work to meet the needs of the clients that you serve. And we're always happy to, have a conversation and meet you all. And this for me is really the most best part of the work, is getting to meet people from around the country who, see that there's more we can do as healthcare providers and willing to step forward and start making that change. So I just want to thank everyone for having us. This is really incredible.
Thanks so much, Shira. And, COVID's been awful in so many ways, in countless ways. But it's also offered some opportunities, and being able to have an event like this, I think is one of those that maybe wouldn't have necessarily happened before, but because that's become the new orientation, that allows us to bring people together, maybe from around the country today, to talk about your most important work. So thanks wholeheartedly. Thank you to the four of you and to the audience for attending, for your interest, for your commitments to this excellent work. And I'll look forward, hopefully, to seeing the four of you again soon. So I think we'll sign off now. Take care, and thanks again.
Thank you. Have a good one.
Thank you. Take care, everybody.
Bye to my fit family and everybody else. Thank you for having us. It was great.
Always
Bye. Miss you guys. Miss you guys. When this is over, we have to find a way to get to North Carolina.
We'd rather come to
Beautiful out
Cali,
there, you guys.
baby.
Or you come to Oakland, but that might not be.
Yeah, let's that. All right, y'all have a good one. It's been fun.
Thank you.